Hi, everybody, and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Kaigenesis, a range of supplements designed for people diagnosed with chronic kidney disease. Whether you need to lower your EGFR or no, you want to raise your EGFR and lower your creatinine, we might have a supplement for you. And I'm joined again today by the wonderful, the beautiful, the amazing, the stellarly wonderful Lindsey Zirker. Lindsey, if you haven't met Lindsey before, which hopefully if you're a regular on the channel you have, is a renal dietitian. She works with the team at Kidney Nutritional Institute with Jessie Anna, and she has a wealth of expert in all things dialysis, having spent an extended period of time in the dialysis unit. And I'm going to speak for you here, Lindsey, but please interrupt me if I get this wrong. But I feel like that would have been a big jumping point to find out if there are better ways to do kidney disease than dialysis. I feel if you were in there all the time, and I know how curious your brain is because it goes down the rabbit holes and it's like mine, that you must have been like, there must be a better way. Was that part of the, yeah.
Yeah, there was a lot of things that, I mean, the planets really did align in making the jump, but that was definitely one of them. Yeah.
Yeah, I just know your brain. You'd just be like, it can't end like this for people. There has to be other ways to do it. And you're
Yeah.
curious enough to go and like, I have to go
Mhm.
investigate this. That's how you, which is why we love you so much. And Lindsey and I, well, Lindsey mainly, she's the one doing the talking and she's the brains behind this operation. But we've been making our way through hormones and their relationship to all things chronic kidney disease. So we've covered insulin, and I think last week we did cholesterol, which is super interesting. And we today are going to make our way into the sex hormones, and we're going to start with the wonderful testosterone and its link to chronic kidney disease, because and we're going to do estrogen because a lot of or a lot of the community in the advanced kidney group do talk about their kidney disease coming on after menopause. But we were also, well, I was super curious, and I'd love to see what you came up with this, Lindsey. Is there a link between testosterone and chronic kidney disease and what that all looks like? But I'm going to hand it across to you to talk all things testosterone. So fill us in. First off, maybe for people that don't know, testosterone, what's its role in the body? Most people think of it as a male hormone, but of course it's more than that. So
hmm
take it away.
Yeah. So, yeah, testosterone, mostly we think of it as like that's what makes men act like men, right? Um, but there's so much more to that. And I feel like that's actually true for so many things that we learn about in the body, that the first function that we learn that it has, that it kind of gets pigeonholed, it gets typecast right into that specific thing, but really there's so much more that it does. And testosterone is no exception. So it is a steroid hormone, which uh, and from the androgen group. And so, as we kind of talked about last week, the importance of cholesterol. You do have to have cholesterol to make many of the hormones, including testosterone. And if you're kind of thinking about, oh, but I thought it was made from like other stuff, you're maybe thinking of DHEA, where it can be DHEA can be converted to testosterone from DHEA. So that is definitely true. So yeah, for men, that is typically testosterone is found in higher levels. Um, Most of it is made in the testes, but a little bit of it is made in the adrenal glands. And for women, it's kind of like half and half, ovaries and adrenal glands, and then there's conversion in peripheral tissues as well. So there's kind of there's a big difference in where testosterone is made in men and women, but it is important for women to have testosterone. Um,
Yes.
yeah, definitely need to have it, because what testosterone does is it helps with muscle mass and strength, bone density, libido, sexual function. It influences your mood, your motivation, and your energy,
Mhm.
fat distribution, and insulin sensitivity. And it plays a role with cognitive function and your overall feeling of well-being. and also helps with erythropoiesis. So that's your red blood cell production. Um, there's probably more things that it does, but I feel like that's kind of like the
Yeah,
big
the
pieces.
violet ones. Yeah. It's so
Yeah.
interesting. I don't know, like, I don't know if your darn Instagram algorithm's doing it, but because I'm 45, it's just like, you are entering perimenopause. I'm like, thanks, Instagram. And so my Instagram is filled with women and perimenopause and all the latest research coming out. I'm like, this is great. I feel so good about myself. But Dr. Marie Claire Harver and Kelly, I can't remember her last name, but she's amazing. She's got the really cool hair. Um, like if you, they're the ones that pop up on my field, but the just how important testosterone is in women, especially postmenopausal,
Mhm.
and how, I didn't realize, but testosterone in women is actually more abundant than estrogen and progesterone, which a lot of people wouldn't know. And
Yeah.
testosterone is converted into estrogen. So we talk about estrogen decline in postmenopausal women, but if you don't have enough testosterone, that does feed into the whole estrogen metabolism, which is why when guys take TRT, they sometimes have to take androlone and other bits and pieces to stop that. They're called aromatase inhibitors to stop that estrogen conversion because you can get that. But it's super
Mhm.
important in women. And it's one of those ones in the US. I don't think at the moment your FDA has it approved for women. Where in Australia we do. We have testosterone is approved as a therapy. We use the androfem cream. It's on our medication base, meaning you can get it for not a horrendous sort of price. But yeah, there's so much research coming out about it with its importance in women and for like you were saying, cognitive health and mental well-being and bone mass and muscle mass and all of those sort of things. So any of our female listeners listening, testosterone has been undersold as how important it is. And in the hormone replacement therapy world, sometimes I've got a lot of my women when we test and we put in, I'll give you some anecdotes, but when we put in testosterone, I've had 3 patients now where you look at the hormones, we've managed to get HRT in, made a great difference, but they're a bit depressed. And then we put in TRT, so testosterone replacement therapy. I had one of my patients, what was she? She was 48. She went and started up a new business. She was just like, I've got all my mojo back. I'm back. I'm like, and it was the testosterone. And then the other one was like, in fact, I think it was Dr. Marie Harver said the same thing. And this patient used the same language. She said, my world went from black and white to technicolor as soon as testosterone came in, like the difference it was making in women. So, a lot of my MS patients and autoimmune disease patients actually also do very, very well on a bit of testosterone mixed in with the others. So yeah, I'm starting to realize just how super important it is for women as well as men. So sorry to add to that, but just in clinical
No,
experience,
it's good.
it's undersold for sure.
Well, it's interesting as you were sharing those experiences and, thinking back through, my research that I did this week. Also because we're seeing a lot more discussion about adult ADHD being diagnosed in perimenopausal women. And I'm just thinking, a lot of ADHD symptoms line up with maybe testosterone being lower. Like how is that, an overlooked, reason? Like, not saying that ADHD is not necessarily a thing for them, but maybe it's just exacerbating, how the brain functions that way, potentially.
That's fascinating. See, I love how our brains are so similar, how you can make links like that. I love that. So why don't you take us through what are the symptoms, men and women, of potential
Yeah.
testosterone deficiency, since we're sort of there? Because that,
Yeah.
I've never made that connection to ADHD, and that's super interesting. So yeah, walk me through what may manifest if you are deficient in testosterone.
So some of them could be like the same for both men and women, and then maybe some might be like more pronounced in the other. But I think like overall, um, fatigue or low motivation, and again, like thinking about that ADHD connection with the low motivation and then the difficulty with executive function. I just feel like that's so tied together. Um, but also depressed mood or brain fog, loss of muscle and gain of fat, um, low libido or erectile dysfunction in men, bone loss, anemia, low endurance level, poor recovery from exercise. Um, yeah, I think those are kind of like, yeah, I feel like that kind of checks it. Like sometimes the different language might catch people more, like loss of enjoyment or zest for life or poor concentration, but that still kind of falls under like all of those things. So those are, symptoms of lower testosterone. I feel like that checks boxes for most people. Some of these don't feel very specific, right?
No, but and I think that's, why it's such a broad area. And, like, I mean, we'll talk about this more when we talk about estrogen and progesterone next week. But, for so long, and it's sort of not quite our generation, but the generation in front of us, HRT was like, well, it's going to cause cancer. And then you've got this generation of women that haven't had it. And it's made a huge resurgence due to these amazing OBYGNs that are, looking at the research and realizing that those black box label warnings and that one study was so flawed. So we're now seeing, hormones sort of coming back to center stage, or it could just be my Instagram algorithms and why I feel like that, quite possibly, but it feels like it's made a big resurgence. But, a lot of my young guys want to, my biohacking crew are asking about testosterone replacement therapy. And if you follow the biohacking longevity stuff, a lot of guys are replacing testosterone because, and I'd love for you to speak to this to, I've got ideas of why I think it's happening, but we have seen a massive decline in testosterone levels in men, full stop, overall over the last sort of 20, 30 years. Male testosterone levels have been on the decline. So talk to me about that, because it's, like I say, 40, 50 years ago, people weren't really doing TRT unless you were maybe like Arnold Schwarzenegger and really into that. Whereas now I feel like all my, and these are young guys, they're in their early 30s, are coming to me saying, we want to do TRT, we want to replace testosterone, or if they don't want to do TRT because, they still want to have kids and they're just worried about, crashing out their ability to be reproductive, they're like, can you naturally boost testosterone? And I'm looking at functional, and I don't know what you're finding, but because I'm reading functional blood tests all the time, and especially these Nutristat tests that I'm doing, which so I'm reading sort of, 15 of them a week, testosterone levels in pretty much all my men are subpar. They are low. We've got either high sex hormone binding globulin or testosterone's right, but free testosterone. So first off, talk to me why potentially there has been this massive decline in testosterone in men over the last 50 years. Like, what's going on? Why are we seeing this huge reduction?
Well, I do feel like, when we say, hey, we're noticing this big shift, I think we always want to have like that little, uh, in context, there is an increased awareness. So more
Yes.
things are, we're getting more testing done. I don't think that's by far like the main reason, but definitely, it's like that thing when you get a white car and you're like, oh, there's suddenly white cars out here. Like there's just an increased awareness, which I think is a good thing. But I was really surprised when I was looking at different things that can cause testosterone decline. When it said aging, a lot of times when they say like, naturally things decline with age, you're thinking maybe 60 or 70 years old. But for testosterone, it's like a loss of 1% a year between the ages, like starting between 30 and 40.
Yeah, yeah, it's
And I
bonkers.
was like, excuse me? And so, I mean, I feel like that makes sense with the perimenopausal piece that, yeah, we're gonna be seeing some different things there. But yeah, that natural decline that seems to happen for whatever reason that I haven't really had a chance to go down that rabbit hole. But I think that's a piece. Um, but obesity is also a factor as we are moving away from that narrow bias of, well, obesity is caused because people don't have self-control and they just eat too much, no, we actually know that it is a disease, and adipose tissue is an endocrine organ, and
Yeah.
the increased aromatase that is available with that extra adipose tissue, it converts testosterone to estradiol. And so, I mean, with again, so many things that are actually like without like we don't understand how they're going to affect us because you have these people who can live the same lifestyle and you can get like a bunch of different body types from it. So it's not to like absolve people of responsibility, but just to acknowledge that it is really complicated, and obesity is yeah, one of the things that can cause a decline in testosterone. um, but also chronic inflammation or illness. So, like our, our population here, CKD. We'll talk a little bit later about specifically how CKD impacts testosterone and vice versa. But CKD, diabetes, liver disease, those kind of things, they are going to cause a decline. Sleep deprivation. Does anyone have that?
Oh, I know. When I was reading on that, I was like, even short-term sleep restriction, like if you get less than 5 hours sleep, can lower testosterone by 15%.
That's amazing. But I also feel actually not hugely surprised because when I was digging into hormones for that hormone chapter, when I was looking into assessment and intervention to help, I was like, how do we really test for this and expect accurate results? Because you can get different results for like T4 is naturally, I can't remember if it was higher or lower in the winter and then vice versa in the summer.
Yeah.
Yeah,
Yes.
there's like weird things like that. And then like, well, no wonder people feel like horrible or just like off at the change of seasons with daylight savings time, traveling, like those kind of things, they have a giant impact on your hormones. They are so delicate. It feels like they're supposed to help us be resilient, but it feels like the opposite. Um,
Yeah.
and so, yeah, sleep deprivation or sleep apnea, those things are going to have a big impact. Um, of
Yeah.
course, our favorite cortisol, elevated cortisol and stress,
Yeah.
that's going to be a thing. Interestingly, low calorie or low fat intake can lower testosterone,
Yeah.
um, which I think is again, we think about the whole low fat craze back in like the 80s and 90s
Yeah.
and
80s and
how
90s. I was in a low-fat household in the early 90s for sure.
yeah, yeah, and how of course that still is like a yeah, it just hangs on there. Micronutrient deficiencies. So zinc, which again, so common in the CKD population,
Yeah.
significant zinc losses. Um, even like in as early as stage 3, a lot of people don't even know they have kidney disease at that point. But zinc, magnesium, vitamin D, selenium,
Yeah.
um,
Boron.
those,
I think that's a big precursor to testosterone.
yeah. And then there's, of course, endocrine disruptors,
Yeah.
so pesticides, BPA, the phthalates, all those kind of things. And then there are some medications like statins, not to keep harping on those, but apparently they cause problems. I mean, but statins make sense, right? Because
Yeah.
if you don't have cholesterol to make it, then, but also like SSRIs, other medications, opioids, glucocorticoids, those kind of ones,
Yeah.
they can cause lower levels. And so I feel like, yeah, not too big of a shocker because all these things that I listed off, I feel like these are things that like we're always trying to like battle and sort out and figure out. So yeah, it's a challenge for sure.
Yeah, and we always talk about, or at least I see a lot of early stage CKD very much linked to metabolic disease. That
Hmm.
whole, like you talked about, and I'm grateful that you said it. As soon as people get into that obesity state, and you're right, visceral fat is its own endocrine
Yeah.
disruptor, and it's crazy. And how it will, block testosterone conversion and estradiol and those sort of things. And so that whole metabolic picture, which so many people have, maybe due to, we sit longer and, poor diet and all of those sort of things. But that whole picture, I definitely see is an undercurrent of this. You'll see
Yeah.
declining testosterone in this. So it really makes sense. And of course, that is a big precursor, which is where I was going to chronic kidney disease. Kidney disease
Mm-hmm.
starts for a lot of people, unless, you've got the big genetic sort of drivers or autoimmune, as a metabolic disorder.
Mm-hmm.
And it starts
Mm-hmm.
higher up. You get the tubule dysfunction going first before we see it turn into a gross glomerular filtrating issue. It generally, for the bulk of it, metabolic disease is the precursor to chronic kidney disease. And so this is just, this falls into that category. So it makes
Mm-hmm.
sense that we're going to see that. So is there anything else you want to cover there or say before we start talking about the link between testosterone and its role in progression and vice versa that you were going to talk about with chronic kidney disease?
No, I think we're good. We can move forward, and we always like to, tangent if we need to. So
Let's tangent away into, yeah. So why does testosterone matter if you've got chronic kidney disease? Why should you be thinking, do I need to optimize my testosterone or even look at it?
yeah. Well, firstly, at least in the dialysis population, um, for men, I don't know that they've actually really looked at it for women, but for men, low testosterone in people on dialysis, in men on dialysis, is really common. 50 to 70%.
Wow.
That's higher than I thought, actually.
Yeah, that's and that is, for context, obviously they're taking into consideration age because we know dialysis is generally age related. So they've factored that
Yeah.
in. So 70% lower even. Wow.
Hmm.
Okay. I
Yeah,
can see how
it's
low those levels would be then.
Yeah, it's a lot. And the lower testosterone levels in dialysis, in men on dialysis, are associated with increased mortality, and naturally that means increased cardiovascular risk because cardiovascular causes are number one cause of death in people on dialysis. So yeah, I was like, well, that's one big kind of umbrella thing, but there are a lot of different factors with kidney disease that can further be a common cause. So, firstly, there's uremic toxins. So, I think when we talk about like endocrine disruptors and stuff, one of the things that maybe doesn't really get talked about with hormones is that I feel like there's lots of maybe like there's lots of what's the analogy I want to use? Like maybe weak links in the chain, or easy ways to breach security to so that hormones don't like actually get from point A to point D. Because when you think about a lot of hormones, there's like the whole hormone production piece and all the cofactors needed for that. And then a lot of them need to be
Yep.
converted to more active forms. And then it seems like the piece that's most often forgotten about is that they actually have to go and be able to get to the receptor. And for hormones, toxins, for whatever reason, are really great at shape shifting and they can just sit in any darn receptor they want.
I love
And
it.
yeah. And so that's a big problem with kidney disease in general is that those uremic toxins, they're sitting in receptor sites for hormones everywhere. So,
Mm.
like, that's part of why thyroid's a problem. That's part of why EPO is a problem. Like, we always think, well, the kidney's not making it, but also toxins sitting in receptor sites. So, it's just going to wreak havoc on every single system in your body because your hormones can't sit in their sites. But also, uremic toxins do impair a lot of hormone production, and testosterone is not an exception there.
Okay. Yeah, that makes sense.
Yeah.
Okay. And then, so that was the dialysis population. I guess it's the same to a lesser degree as we move along
Yeah. Hmm.
progression. Is that fair? And
Yeah.
did you, in the research, was there any protective mechanism by having optimized testosterone against having chronic kidney disease?
Um,
Have they looked that far? They may not have pulled that together. Because I'm like, because everything you spoke about with testosterone, if you were optimized, it means you're going to have less insulin resistance, more muscle mass, meaning you got less metabolic disease. So I'm like, surely having optimized testosterone, I mean, it makes sense to me, would be protective against kidney disease, or is it just no one's done that study? I mean, like I say,
I
my
think I'm looking in my notes. So I think the studies that have been done haven't been very like awesome cause and effect type studies, like to really prove that. But like retrospective studies, they're showing that this one was in veterans,
Mhm.
48,000 veterans that had lower testosterone. They found that those who received testosterone replacement therapy, they had a delay in their progression of kidney disease and a 25% lower risk of mortality. So, I mean, it's a pretty big study, but of course there weren't like they didn't control for all the variables and stuff. Um, but I feel like in these kind of situations, I feel like this happens a lot in therapies where it's like, okay, we don't know for sure the cause and effect piece here, but we do know that low levels of this are not normal in healthy people. It's not natural, and it is causing a negative impact on other things. So even if it doesn't slow the progression of kidney disease, even if it doesn't change mortality risk, it is going to improve quality of life. And so I feel like if the risk is not high for other negative side effects, like why not? Right?
Well, that's a very, very good point. I mean, that's what all the research is now coming out about,
Yeah.
postmenopausal women and putting it in there. But the side effects are, as long as you're adjusting and testing, that, there
Yeah.
are very little side effects to putting it in. So, well, talk to me about that. So, if we're looking at full-on testosterone replacement therapy, I mean, if you abuse it in men, there are side effects, but walk me through what that looks like. So, yeah, what does that look like as far as a therapeutic? And then we'll talk about natural ways to boost testosterone and just things you can do in the diet. But if we go straight to the TRT in men, walk me through what that looks like for men, side effects, what people would have to look at, because we're talking about generally injecting, but there are other routes that you can get testosterone in. Talk to me about all things TRT, Lindsay.
Yeah. So testosterone therapy, like you mentioned, of course, I feel like if you're going to actually get that therapy, then you want to make sure that you and your provider understand what does like follow up look like. This isn't something that you can just like take and then never follow up and go along your merry way. Um, um, so definitely getting those initial blood draws done, and but then also making sure, as with any kind of lab, because we know that hormone tests can be finicky. So you want to make sure that you've looked at those things in context, like also what are the risk factors, like we talked about um, those causes and those and symptoms, and make sure, okay, is this really the best option? And then you move forward. So that's, I feel like the first step is just doing that. And then once you've gotten the testosterone tested and the doctor's like, yep, okay, seems like um, you should, get this therapy. Like you said, there are a lot of options. Um, I typically am a little bit more removed from that because I cannot prescribe those things. So I'm usually referring patients to their doctor and saying, here's the questions you need to ask. Here's the things you need to ask about, and the type of follow-up to do. But I think that yeah, there's multiple options. Do you have a favorite like option that seems to work better for people?
Look, I think from all, and again, if we're talking about full testosterone replacement therapy, like you, I have to refer across to a good doctor that will do it. Rather, I'd be looking at natural ways of doing it. But testosterone cypionate as an injection, generally 3 times a week, is generally the one that's got the most research behind it, the one that's the standard one that they're using definitely in the US. You can do like Troche's. I know from doing enough watching of gym bros and listening to that science. And in fairness, the gym community are generally, bodybuilders are generally quite far in front when it comes to bringing in new
Yeah.
molecules and things like that. So I generally am listening to them for trends, but they don't generally like the Troche's because of poor absorption. So generally it's intramuscular injections, which is where most of the blood tests, most of the studies are done on.
Hmm.
Then you obviously have to be testing for a whole pile of things like you mentioned, and keeping an eye on luteinizing hormone, because high amounts of that will suppress
Hmm.
luteinizing hormone, which is what will tank out your testes' ability to produce sperm. So intramuscular injection, it's testosterone, ephinate, cyprinate's the one I normally see. And then in Australia, we've got one called Redron, I think. And generally you're doing it weekly to fortnightly, depending. And you did for like every 8 to 12 weeks, and then you're retesting and checking. Then you can have subcutaneous.
Hmm.
It's a gentler absorption curve, and it lowers the risk of rises in hematocrit, which can happen with the intramuscular ones. You've got the transdermal gels, which is what you can prescribe for women. It's a much steady delivery. It mimics circadian rhythm. It's not invasive. It's easy to try titrate dose. I will admit here, I'm on androfen, so I've like optimized all my hormones. It's part of what I'm doing for MS and things like that, and I definitely feel better on it. But that cream is a bit of a, you're drawing it up. It's I can't. It's not as precise as you would be doing an
Mm.
injection and things like that. Side note, no, my dog is also on testosterone replacement because he's castrated. So he and I both cream ourselves together in the morning, and it's a complete change of personality. So it works for them too. And then you can do the buccal sublingual
Hmm.
testosterone lozenges. And I know a few of my female colleagues in the gym use them that way as well. You need to generally dosing a couple of times a day. So, and I think you can do patches as well, but I
Yeah,
don't
I've
know
seen
a
that.
lot of men doing transdermal patches. So generally women is the transdermal cream. That's what's approved in Australia. And I know what the push is to try and get it approved in the US at the moment. And then men, yeah, it's generally the IM route is what you're going to get better results with. You
Hmm.
can sub-Q it if you've got issues with hematocrit and things like that. So yeah, that's what I see. And then of course, and we won't go down the full route, but if you're a man taking it and you still want to have children, and you have to be monitoring your luteinizing follicle stimulating hormone and liver panels and things like that, sometimes you can use the aromatase inhibitors alongside testosterone to make sure it blocks the conversion of testosterone filtering down to estrogen, because if you're metabolic and obesity, you're going to have that natural shunt going on inside of the body anyway. So you're going to be taking TRT. If you've got a lot of central obesity, as you mentioned earlier, that endocrine tissue is still going to take it and go delicious. And then you get this rise in estrogen. And then you have to look for like men get nipple budding and, man boobs is what we call it in Australia. I don't know what you call it in the US, but men can get nipple budding. And that is the
Yeah.
testosterone is converting down through estrogen. So then you've got your aromatase inhibitors that potentially need to go on there. But that's why you absolutely need to be working with someone who knows what they're doing, how to read blood tests. You need to be checking those bloods when you first go on it. And you have to also know that you're at an increased risk of clotting for the first 6 weeks of taking any hormone replacement therapy. So you have to be all over that stuff. It's not something you do by yourself at home without a provider, is my
Yeah.
short takeaway with that.
Yeah. And yeah, that was good overview. I forgot about the nasal one. But yeah, so the monitoring typically, from what I understand, it looks like initially you actually don't just do, I forgot about this part, one test. You'll have to do two separate morning tests, which I was like, okay, that's good. I,
Yeah. Back to your
yeah,
point of what you were saying before about how finicky hormones can
yeah,
be. Yes. Yeah.
yeah. And then, like you mentioned, you're checking, the other hormones, luteinizing hormone, follicle stimulating hormone, prolactin, all those other ones.
Yes.
Um, and and then once, like, if you do move forward with it, then kind of like the maintenance thing is once you're stable, because you already mentioned, 4 to 8, yeah, 6 to 8 weeks.
4 to 6. Yeah.
Once you're stable, then every 6 to 12 months, depending on symptoms, right?
Yes.
But the ongoing monitoring, like you said, the hematocrit and hemoglobin, um, but also lipid profile and liver enzymes. You mentioned the estradiol, and then also doing sleep apnea and cardiovascular risk assessments, um, because of
Definitely.
those. Yeah.
And I have to say, I've got a couple of my men in their 50s and they are ADHD. So I feel like maybe this comes a part of that personality that just think more is more. And so abuse testosterone. And then all you do is your luteinizing hormone goes into the toilet. And,
Yeah.
if you've got too much visceral sort of fat, you're going to get an increase in estradiol and increase your risk of cardiovascular disease. So testosterone, TRT, isn't a more is more, it's an optimization. You should be optimizing testosterone rather than replacing it. I always like that word. A
Yeah.
lot of hackers use. So you can't, and it's not something you can stuff around with because you will increase your risk of cardiovascular disease and things like that if you abuse it, which is, it used to happen more in the 80s and 90s. I think people now are understanding about optimization and things like that. But I have had a couple of my guys, and again, I'm not overseeing them, they're seen by a TRT specialist, but when I'm checking their stuff, I'm like, are you dosing correctly? And they were like, no. I'm like, your testosterone is like 5 times on the upper limit. And I'm like, you need to go back and check your luteinizing hormone because the recovery from that, when you suppress your pituitary gland and your luteinizing
Yeah.
hormone, is generally 12 months for your body to come back. So if you're a young guy wanting to have children, if your luteinizing hormone is in the toilet, you're not producing sperm, so the spermogenesis process has disappeared. So it's generally 12 months to get that back on track, maybe a bit
I
faster.
didn't realize it was that long. That's a long time.
It's a
Yeah.
really long, I'm giving you worst case scenario, but it's at least six
Yeah.
months.
Yeah.
Yeah, and so, if you want to have children, you've got to, and people are having children later, women don't, our windows open and close, so just things to think about if you're a younger guy using TRT or if you abuse it or if you
Hmm.
think there's more, there's some certain risks there you need to be aware of.
Well, and I think also sometimes, like you don't really see cardiovasculars. Like, of course, we know that's important, but it's not something that, like, it feels kind of abstract sometimes. But the hair loss that comes with higher testosterone, that's pretty easy to see. And
Yeah.
also the aggression, the irritability, acne, oily skin, and then in women specifically, a lot of those PCOS symptoms that we hear about of, the facial hair, deep in voice, irregular cycles, and then of course infertility. Those are things that I feel like people, like they can see that and they can be like, yep, I don't want that.
Yes.
And so it makes it a little easier to say, okay, yeah, balance is good, optimized is good.
Yes. No, very good points to make there. Um, Yeah, we won't go down the full TRT route. We don't need to talk about aromatase inhibitors and human colonic gonadotropin and all the things that they can use as well. But it might be worth talking about natural ways to raise testosterone because I think a lot of people that come to me like, are there natural things that we can do, especially my young guys, we're still thinking about having children. And I will
Hmm.
say hormone optimization, if you're really low and you're looking at chronic diseases like kidney disease, I probably would just suggest people do TRT to really put the brakes on things. But once you start TRT, that wagon's hard to get off. Like if you once you optimize it, and if you don't address all the things underlying, generally when you come off it, your testosterone levels are going to fall. So you're kind of, once you sign up for it, if you want to stay that optimized forever, you're signing up for life. And you need to be doing all the stuff underneath it to optimize. So talk to me about things that people can do that will naturally help boost their natural testosterone levels.
Yes, that I'm looking again at this list and I'm like, oh yeah, this actually works for like optimizing most hormones.
Yeah.
And that's the thing too, is if one of your hormones is off, there's cascading effects like everywhere. And so, um, kind of like we talked about earlier, it is really, really important that you do try and figure out what is actually causing this. I do feel like you mentioned, if people are really, really low, like just getting them on it, because if you're wanting to do lifestyle changes and you have no energy, you have no motivation, then how can you do lifestyle changes? Like, obviously, that's not going to work.
Yeah.
But if you just put a band-aid on it and take the testosterone without looking to say, well, actually, maybe it was this other, hormone pathway that was off, or maybe it is these two or three lifestyle choices that I need to correct that is the problem. Because if you only correct testosterone, like,
Mhm.
yeah, it is going to help other things, but those other pathways are still broken. So,
So,
um, but yeah, so things for testosterone, adequate dietary fat. So, and people are like, well, which kind of fats, which kind of foods? When you look at the breakdown of types of fats that are in different types of foods, they're all mixed in, right? Like, you're not going to just be like, I'm going to have this one because there's only, you know, polyunsaturated fats in it. That's a lie. Like, those things don't exist. So I always say, let's make sure we get fat from a variety of different sources. Then you'll get a nice, lovely mix of those things. Um, you also need sufficient protein, and
mhm.
resistance training can help with that.
Yeah.
And then if we think back before, of the things that lower testosterone, it's the low fat and calorie restriction.
Yes.
And I feel like in our CKD population, especially with the non-dialysis population and the big push for like lower protein plant focused diets, while there is like so many benefits to that, if you aren't eating adequate calories, then you're going to have worse outcomes than if you hadn't gone on the low protein diet at all.
Yeah.
Because if you're choosing low protein, that means the protein has to go for the things that only protein can do, like build your muscle and make immune cells and um, do all those things and transport nutrients. Whereas, we always think of, well, you need to eat so you have energy. Well, your body can use fat and carbs for energy, but if you're eating really low protein and then you're not eating very much fat or carbs either, then your body is going to get that protein from somewhere, and it's just you're going to be a cannibal. So don't do that to yourself because you'll have low testosterone and be a cannibal. Your body will eat itself. Um,
Yep. True story.
so so yeah, if you want to have balanced hormones, but because we're talking about testosterone, if you want to have healthy testosterone, you have to do that nourish first approach. Make sure you're getting enough fat, make sure you're getting enough protein, and then those micronutrients we talked about before, specifically zinc, magnesium, vitamin D, and selenium.
Mhm.
Um, and, it's a challenge because healthy body weight is also one of the things. And so people think, oh, okay, so I need to lose weight. That means I need to eat less. But so much of the time, like eating that very low calorie diet, it's going to suppress your metabolism. And then if you're also not eating very many calories, with obesity being its own special endocrine organ, we've learned a lot more about leptin, which is one of the things that helps with metabolism.
Yeah.
And and they found that a lot of times people dealing with obesity, they're leptin resistant. So you know what that means? You literally cannot use fat for fuel. Your
Mhm.
body can't. It won't. So you can starve to death and like
Mhm.
not and that's the thing why like depending on what's going on with your endocrine situation, people think, oh, I'm going to do keto for weight loss. But if all you're eating is fat and you're doing intermittent fasting,
And you let.
then how is your body going to get any energy if it can't use any of your fat stores for fuel, like
Yeah.
with the
It's
fat
a
that you just
really
ate for fuel? And so I mean, I feel like that is another highlight of just because this worked for one person doesn't mean it can work for another. It's really important to think about your own individual situation. And there's nothing wrong with like looking at options, but talking with your team and saying, is this something that could work for me? And if it's not, then why not? So that you can understand what's going on with your body. So healthy weight is important, but a healthy weight where you um, don't nourish yourself, like those two things can't exist. So that's a big soapbox I have, obviously.
No, no, you're right. It's super important. And people forget that whole, yeah, that some people, if you're fully leptin resistant, won't burn fat. So, yeah.
Yeah. And it's kind of a similar situation also if you're in chronic stress mode. When your cortisol levels are high, it's very difficult to burn fat. And then there's also genetic SNPs that mean, yeah, that's just not going to be the way it happens. Like,
Yeah, no,
it won't.
you're absolutely right. I'm going to add B vitamins and omega-3s, but
Oh,
omega-3
yeah. Thank
is
you.
just
Yeah.
another good way to get fat and to bring down inflammation, right?
Hmm.
Okay, so micronutrients, what other things do people need to do? You talked about stress reduction, cortisol, strength training. Um,
Yeah. Sunlight exposure because
yes,
vitamin D,
yes,
but also circadian rhythm. For any hormone stuff, you got to get your circadian rhythm under control.
yes, so true.
Yeah. And then for some people, cold exposure can be really helpful. Um,
Does boost testosterone
for,
levels. It's been,
yeah,
yeah.
for people who have like significant thyroid issues, or maybe you're dealing with adrenal fatigue, or as conventional world is starting to recognize HPA axis dysregulation, um, cold therapy is not a good option. But for a lot of other people, that can be. And if you're thinking, well, is it a good option for me or not? If you do it and you feel like crap, it's not a good option for you.
See, I love cold therapy. I've got a great big cold plunge out there. It's my bad boy, and I love it. And
Yeah.
yes, yeah, there's so much science out there on cold plunging, so people can go and
Yeah.
listen to us on
Yeah, it's
that. But
perfect for some people, and then, for others it's not
yeah,
the right thing. Um Other things that you can do is, taking a look at your diet, refined carbohydrates and sugar because of the role they play with insulin resistance, and that means that increased aromatase activity, converting the testosterone to estrogen. So I mean, I really do like to focus on let's add this into the diet rather than saying don't eat these things unless it's like really serious. Because I mean, refined carbohydrates and sugar, it is a little bit of a boost for your dopamine. But if you're going to have them, it helps if you don't eat them by themselves, right? Like if you're eating a higher fiber meal and then you enjoy some of those refined carbs or sugar, that is going to help. You don't need to be totally purist about it and eschew them totally, because I feel like those kind of extremes make it really hard for us to have healthy relationships with food. But there are things that you can do to still put them in on special occasions or once in a while, that it's not going to totally throw off your hormones, throw off your health goals. But a lot of refined carbs and sugar, that's definitely going to, like you said, metabolic issues are a root of a lot of chronic conditions. So, um, alcohol is also in that category. So,
yeah,
yeah. Also, chronic endurance exercise without recovery time. Or if you have genetic SNPs where you don't manage oxidative stress well, or your recovery time is slower for other reasons, that is going to lower your testosterone. And then, of course, the low fat or calorie restriction. So, I mean, when you look at this list, it's like, I want to be like, not do extremely crazy things, but I just kind of want to be healthy. That's what this list is. Like,
yeah.
eat enough food, get your vitamins and minerals in, sleep, put your face in the sun, manage your stress, move your body. Those That's what your hormones want.
And I'll
So,
add from a herbalist point of view, there's quite a few studies done in Tonkat Alley. People will have heard about that. It's a herb that can boost testosterone, and shilajit, which,
hmm,
is something that, yeah, I think probably because of all the co-minerals, boron is another one really important as a cofactor for the conversion of testosterone. So, If someone's come to me and saying we want to do it naturally, fenugreek seeds maybe as well, that mainly because that clears estrogen, but there's some
Mm,
herbs that we might try with people along with everything that you just mentioned. Generally, it's the optimization, getting people into the gym and strength training, because the more muscle mass you have, the more testosterone you'll naturally build as a side of it. And there's a
yes.
whole thing about pushing heavy weights. That's a testosterone boosting exercise in and of itself. So
Yeah,
it's a good natural
that's
way.
very true.
Yeah.
Yeah, that's perfect. Thank you. Yeah. Looking through my list, see if there's any other
Anything else
pieces
we've
in
missed
there.
when it comes to Mr. Testosterone?
Um, no, I think we've pretty much covered those big pieces. So, but I mean, I think like circling around and like putting it in the forefront for CKD, like there are a lot of reasons, just like anybody could have lower testosterone, but that is added on a decent amount because of kidney disease, because of those uremic toxins we talked about, the inflammation and oxidative stress, and also anemia and low erythropoietin. That also reduces testosterone synthesis. We already mentioned like malnutrition, low intake of calories and stuff like that. Um, and also, like if you're on dialysis, dialysis related loss of nutrients.
Yes.
That's a piece as well. And there are some hypertensive medications that can contribute to lower testosterone, but I didn't go down that rabbit hole to see what those are.
Yeah, I don't know what they
Um,
are either. I just know about SSRIs and proton pump inhibitors and Lipitor statins.
see if I can find that real quick. Um, Beta blockers can,
Okay.
um, like all the ones that end in the LOL, not
Okay.
funny. Um, and and thiazide diuretics may in as well, and ACE inhibitors like lisinopril, which is a pretty common one.
Yeah, it really is. Okay.
Yeah.
I didn't know
So
about that.
yeah, I didn't either. That's why we do these things. We learn a lot.
We do.
So yeah. So yeah, it's something I think can be helpful. I was doing a dive into just like the comprehensive metabolic panel because, the whole, well, I feel horrible. I'm going into my doctor and they say my labs are fine, so they don't know what's wrong with me
Yes.
situation.
Yes, I
And
know
so I
this.
was like, right? And so of course, like there's the piece of where, the comprehensive metabolic panel, like yes, it is going to show things when things are really wrong. But if you're in the dysfunction phase, then it's not going to show things up. And so I was kind of thinking about it. I was like, why is that like that's the test that they run when you go in for your annual physical. But why? Like it's not like it's going to catch big things. And so if like on that test, if you go in and you're like, yeah, I'm tired and I don't know, maybe I'm depressed and it's hard for me to sleep and I feel like I can't regulate stress. Like I'm just freaking out about everything. And then they'll be like, well, maybe you need to go see like your therapist, which is valid to a degree, right?
Yeah.
Because that's a tool in your box, but it's not really like, well, you just need to like work harder at adulting. Like that's not really the answer. And and so I just thought like why why don't we have it work that where okay, fine, we run the comprehensive metabolic panel, but why don't we add on things like just basic hormone stuff or like the Nutristat or Nutri-Eval. That is going to catch the dysfunction pieces and like
Yeah.
that would be so much more insightful. And I feel like, I don't know, at least here in the US, I feel like people get extra rewards or benefits if you like go do your annual physical. But most of the time, it feels like such a freaking waste of time because you go and you're like, yeah, I don't really feel great. And okay, maybe they'll run a TSH if you're tired, but you don't really get any helpful information. You've had to, spend probably 2 hours with travel time and extra waiting and everything to be told you're fine. And and then you're not in a position to prevent anything from happening.
Well, and that's the point, isn't it? Like those annual physicals are screening for disease. We don't screen for optimization and optimized health. That's not how the sick, and that's why I'm like, we're in a sick care system. We're not in a healthcare system. We're
Yeah.
just looking, okay, your limbs are falling off, and okay, you're stage 5 kidney disease. Now we know how to fix you versus you're suboptimal. And that is diet, lifestyle, nutrition. That's our wheelhouse, right? So that's why we're so
Yeah.
obsessed with stuff. But to your point, that's why working with someone like you, or a functional practitioner or a naturopath or whatever, we're all about optimization, and we're all about, like, I look at a lab range. Some of my patients be like, my doctor said I'm fine. I'm like, I just had a 15-year-old boy, and they're like, they say he's fine. I'm like, for 15-year-old in a Tanner stage 4, which is how they rate puberty. I'm like, he is so low in testosterone, it's not funny. His growth hormone is so low. These should be
Mm.
peaking at these times. And then go back to the, oh yeah, you're right. Send off to an endocrinologist. Like, yeah, that stuff boggles my brain. It's like they're not looking for optimization. We do. Like, how do we optimize this person to experience full wellness versus let's just get you out of bed and functioning in the 9 to 5. That's, we're not about that stuff. So, and unfortunately, those
Yeah.
tests aren't looking for that.
Well, and I don't know, I feel like that's honestly part of burnout in the healthcare system because like it's so boring as a practitioner. It's so just like,
This is why you're not in dialysis anymore. Your brain was like,
well, I mean, I did like for the large majority of the time I was working there, I really did love it. Like I had a great team that I worked with. My doctors are awesome. And I did really feel like, I was able to help my patients, I don't know, maybe the first like couple years I really didn't know what I was doing. But once I kind of but yeah, like thinking about how, you know, you're in the disease state and that doesn't mean there's nothing that can be done. But when you think about all the things you can do for prevention or slowing progression, um, and not only that, but again, the quality of life situation, that's a big deal. And it's such a big motivator for feeling like it's worth it to make the effort for behavior change,
yeah,
and changing your diet and your lifestyle. Um, I don't know. I just feel like that's got to be a part of the burnout for healthcare providers when it's just like hopeless and boring. Whereas, looking at how do we prevent, how do we optimize, that's just so much more interesting. And so, yeah, like I don't want people to feel like, oh, I'm already on dialysis, no hope. That's definitely not the message. But even if you are on dialysis, there are still like, I mean, that's where most of my uh like understanding and stuff with testosterone came from because my doctors actually were a little more proactive about that. The social worker would bring up, hey, they are feeling more fatigued. They are feeling, more mood issues and stuff like that. And the doctor would be like, you know what, let's check your testosterone. That's a really common issue in our dialysis patients. That's where I first heard about it. I never learned anything about that in school. And so, I mean, knowledge is power. Understanding what's going on in your body is power because if you don't have providers who are maybe a little more proactive, you can at least ask the questions and then they can be like, oh yeah, you know what? Let's check that out. That'll honor your health values, hopefully, and do that. So
yeah.
still
Well,
plenty
kudos.
to be done.
Yeah, and kudos to your team. I haven't seen that so much in Australia, so that's amazing. So that's
Yeah,
great.
I had a really good team that I worked with. Yeah.
Yeah. Anything else you want to add about our friend testosterone before we sign off into the wild and the wilderness for the day?
So I think maybe, especially for women, they may feel really nervous about getting testosterone therapy, right? So I think it's totally reasonable to have a conversation with your provider and say, hey, like, like anyone would, where what would be the cause of this? But for some people also using DHEA can be an option as well as the other diet and lifestyle things if you're not feeling really confident or comfortable with going straight to testosterone, and giving that a trial with your provider, like checking things out. Um, because we definitely don't want to have fear making decisions for us about our health. So if you're feeling fearful about testosterone or any other kind of piece, just be like, I'm feeling uncomfortable about this. What are my other options? So that either you can kind of rule things out so you feel more comfortable with it, or you find something else that really just work better.
Very good point. And I will also add, we'll have to do a conversation about this one because not a lot of people know about it. Pregnenolone.
Oh yeah.
Pregnenolone, is as far as the body goes, it goes pregnenolone, DHEA, and then testosterone, and then cascades down. And pregnenolone sits right at the top. I put a lot in it's a really good point that you just made. People that are unsure, or if I've got hormone panels coming back where everything's tanked, I will start them on pregnenolone. I was on a podcast, watching a webinar years ago where he's an age specialist, and he was 80 and he looked like he was in his 50s and his brain was still working, and
Amazing.
he was amazing. He was using carbon 60 and pregnenolone, and he was like, they are the two things, because pregnenolone used correctly will master all your other hormones. And so you and I will have to do a podcast on that, because I went down the pregnenolone thing, and I do recommend it to patients. It's something that I take as well, and it will feed that entire pathway, and it's one step above DHEA. And you can buy it online. It's not something you need a script for. Nootropics Depot, they've got a really good one, sublingual one. But yeah, do all your hormones first. I wouldn't be supplementing anything, to your point, until you've really gone right through your panels and had a look at it. Hormones are finicky things. If you go bulking one up and not looking at the whole pathway, but they're all going to move that way. So make sure you're someone who knows what they're doing when it comes to hormones. And that will generally be, if you're looking at full-on replacement therapy, you're looking at a functional integrated GP or someone that specializes in hormones to do that. That's falls out of our scope a bit. Amazing, Lindsey. Thank you. I feel like that was a really good deep dive. We're going to do the female hormones next, so women don't feel like you were left out, although testosterone is super important for women too. So we'll look at estrogen and progesterone next time. Lindsey, as always, thank you. If you want to work with someone like Lindsey, I'll put her details in below, but kidneynutritionalinstitute.org is the website. They're running programs all the time, lots of free stuff that they can download. Lindsey does telehealth, meaning no matter where you are in the world, she can work with you. And if you're in the States, your insurance will, if you've got it, might cover your consult with the lovely Lindsey. And if you want to know more about what we do, head to www.kidneycoach.com, and you'll find us on Facebook and all the other socials that way. Lindsey, as always, thank you for your time, your presence, your brain, and your research. I always appreciate you. And for everyone listening, thanks for being part of our community. I look forward to seeing you all next time.